of our ignorance, we may not realize the pathology in the female genital tract, involvement, or we may cause an inadvertent injury. So how to take care of that, how to prevent that, and what to do if it happens, we will discuss. And Dr. Yashwant is at the Postgraduate Institute of Medical Education and Research in Chandigarh. And the discussers are two of my colleagues from gynecology, Dr. Ranu Patni, who is a senior consultant in gynecological oncology, and Dr. Priyanka Goyal from Department of Gynecology at my institution. Yashwant, over to you, please.
Okay. So can I get a share screen?
उनको enable करें share करने के लिए.
So this is going on. I think it's this.
ये नहीं है, ये शायद नहीं है.
Yashwant, are you able to share?
No, sir. I have not submitted any presentation, sir. I had to share it from here.
Meaning, are you able to share your screen?
No, sir, not yet.
आप उनको होस्ट कर दिया है? Try now.
No, sir, it's still disabled.
आपने स्टॉप शेयरिंग कर दिया? क्या प्रॉब्लम है? तो बीनल को फोन करो ना. टेक्निकल ग्रुप में प्रोग्राम पोस्ट करने का पर्पस यही है कि सबको पता होना चाहिए नेक्स्ट स्पीकर कौन है. हुई है अविनाश की टीम? को-होस्ट बनाने में कितना टाइम लगता है? वहां पर कौन मैनेज कर रहा है आपकी तरफ से? नहीं, ऐसा कैसे हो सकता है? वो तो जूम का फंक्शन है। आप ही तो होस्ट कौन है अभी? यशवंत,
Sir,
आप एक बार लॉग आउट करके दोबारा लॉग इन करो।
I'll try, sir. Yes,
हेलो,
sir. I can
यशवंत हो गया? यस, इट इज
share.
डन।
Yes.
बट दिस इज नॉट एक्सेप्टेबल। जूम इज द इंग्लिश लैंग्वेज ऑफ टुडे। अगर आज की डेट में हमें जूम मैनेज नहीं करना आता तो देन इट्स नॉट एक्सेप्टेबल। Yes, we can see your
Yes, sir.
presentation. Please start.
Just a second.
Screen squeeze.
Yeah, go on the full screen mode, please. Yashwant?
Sir, you can see the slides now, sir.
But go on the slideshow mode, full screen.
Now,
नहीं, अब तो we can't see your presentation.
now, sir.
Not yet.
I'll just again reshare it, sir. I'll see.
Yes. Yes. Okay. Please start.
Yes, sir. Good morning. My apologies, sir. I could not be there because I'm stuck in Chennai because of flights. Today, myself, I am Dr. Yashwant. I will be speaking on surgical anatomy of female genital tract in rectal surgeries, which is of prime importance when we are doing a rectal surgeries for malignancy or other diseases like prolapse or diverticulitis. So, in-depth anatomical relations and its clinical implications has a prime importance when we are doing a rectal surgery operations, which can alter our operative considerations or decisions and post-operative quality of life or post-operative complications, and which can influence patient's quality of life and our practice. So here is a brief basic structure of female pelvic anatomy, where it is divided into anterior compartment, middle compartment, and posterior compartment. Anterior compartment is formed by bladder and urethra. Middle compartment is formed by uterus, cervix, and vagina. Posterior compartment houses rectum and anal canal. So, in-depth knowledge of structures like rectovaginal septum or fascia and denovelous fascia, pouch of Douglas, and pararectal spaces is essential when we are performing a rectal dissection, so that you have to avoid complications like sexual dysfunctions, rectovaginal fistulas, or rectal injuries. So, coming to the pouch of Douglas, it is the most dependent part in the female pelvis. Anteriorly, it is bordered by uterus, posteriorly by the rectum, and it is continues up to the upper part of cervix. And it is most commonly involved in conditions like diverticulitis, endometriosis, pelvic abscess, and in rectal malignancies. So it has a major role in staging of rectal malignancies. So here is a short video where we have done a lab APR for a patient who had a low rectal malignancies. Here we can see that uterus is atrophied and she had a small fibroid, and we used sutures to retract the uterus to achieve a good exposure of pouch of Douglas. Her pouch of Douglas was very deep, uterus was atrophied with a small fibroid. So we have used ethylene 2-way 2O to transfix the uterus to the anterior parietal wall and used for retraction to have a good amount of exposure to the pouch of Douglas. So once uterus is retracted, we can see a deep pouch of Douglas. Anteriorly, it is covered by uterus up to the cervix, and posteriorly rectum can be seen. So coming to the next important, denovelous fascia. In male, it is well defined, but historically it was debated in females. But the recent surgical evidences supports that female too possess a two-layered fascial between rectum and vagina. Anteriorly, it covers the posterior wall of vagina, and superior to this layer lies it lies superior to the vaginal venous plexuses. Posteriorly, it invests fascia propria and covers the anterior wall of rectum. Between the two facial layers lies the rectovaginal avascular plane. It is the ideal dissection route for rectal surgeries and TME. And there is a dictum that fat belongs to the bladder or vagina and the fat belongs to the rectum. That means the fat should remain on rectum or under vagina, and there should be a clear dissection between the avascular plane. If there is any bleeding, that means we are out of the correct plane. So next important structure in the female genital is rectovaginal septum or space. It is a potential space below the pouch of Douglas in the retroperitoneal space. Anteriorly, it is bounded by uterus and posterior vaginal wall, and posterior boundary is the rectum below peritoneal reflection. Lateral boundaries are formed by uterosacral and cardinal ligaments. The pouch of Douglas forms the roof. Floor it extends up to the levator anal muscles. So dissection should be continued distally up to the levator anal to expose pelvic floor and the perineal body sometimes to have a good amount of TMA exposure, and when you're doing a proper rectovaginal fistula repair or draining any complex fistulas or abscess drainage. So coming to the next important, like pelvic plexus, which lies in male as we see in male, it lies along the periprostate rectovesical septum. Even in males, it is in relation to the rectovaginal septum. It lies on the anterior to the posterior wall of rectovaginal septum. Here, a red arrow shows a dissection plane anterior to rectum, starting from right side to the left side, and it should follow inverted Y shape to avoid injury to the hypogastric plexus, which can give rise to branches to vaginal, urethral, and bladder and even for the injury to these structures can cause incontinence, dyspareunia, or sphincter dysfunctions or bladder dysfunctions. So on the right side of the image, we can see once we dissected the rectovaginal septum along the denovenous fascia, we can see the vagina lies anteriorly and the rectum should be posterior, and it should be a fine, sharp dissection using a cautery or other energy devices. So coming to prevention of injuries, that we should have a proper knowledge of complications, and then only we can prevent the injuries. Like doing a preoperative evaluation, we should have a complete gynecological history about any pelvic inflammatory diseases, in use of intrauterine devices, previous pelvic radiations, or any previous pelvic surgeries that patient has undergone, or there is any radiation history. And after that thorough history, we have to perform a thorough perspicular examination, bimanual examination, and rectovaginal examination. If it is a premenopausal woman, we should exclude pregnancy, and that fertility should be discussed before going for any form of treatment like neoadjuvant therapy or rectal surgeries. And previous history of any endometriosis or chronic pelvic diseases or any history suggests of vaginal atrophy can warrant having a high chances of intraoperative complications or risk of rectovaginal fistula, which has to be counseled properly in preoperative period. So prime importance of preventing rectovaginal fistula is like having a knowledge about the complication, how it occurs, and how to prevent. Even after taking due care, sometimes rectovaginal fistula can occur because of ischemia of the posterior wall of vagina, or if there is any local sepsis because of anastomotic leak, or if it is a direct vaginal injury because of the surgical or energy devices, or inclusion of vagina when we are applying a surplus stapler per rectally. So key prevention is to perform a sharp dissection into the rectovaginal septum and maintaining proper TME plane along the fascia propria, and to have a aim to show that there should not be a proper devascularization of vagina. It should be a proper sharp dissection within the vaginal fistula, so that we should not go inadvertently into the vagina. And sometimes we can use a vaginal retractor or obturator when you are applying a stapler firing in LR surgeries or rectal surgeries. So here is another short video where we wanted to show that how to identify the rectovaginal septum. We can find a white line. We have inside the pouch of Douglas. Here, once the rectum is retracted superiorly and posteriorly, vagina is retracted anteriorly, we can see thin reticular fibers in between, and fat lies posteriorly. We can see at 1 o'clock there are thin reticular fibers. By giving a proper contraction, we can see just on incision it opens up. Rectovaginal septum will opens and creating a space. And the dissection continues anterolaterally and caudally up to the levator angle. A proper avascular plane has to be achieved. So another intraoperative complications what we can find is having a giant fibroid of uterus or any pelvic inflammatory diseases or radiation which has caused fibrosis of the pouch of Douglas can complicate our dissection. And if there is any association of hereditary non-polyposis coli, if it is diagnosed, and simultaneously patient should be offered for hysterectomy or bilateral sanjoy. And sometimes ovary can be seen involved on table because sometimes we cannot detect it clinically, and it can estimate mets to the ovaries like transmesomic metastasis can be seen up to 3 to 8% in colorectal malignancies, and can be directly seen when we are performing surgeries. So high suspicion and management like bilateral salpingo-oophorectomy can be performed. Another entity which can be seen in post-operative period is like cystic pelvic mass happens because of the trap ovaries, because of the fibrosis or the obstructions of fallopian tubes and ovaries. So this can be prevented by doing a ovarian transposition when we are performing a rectal surgeries. The ovaries can be fixed to the anterolateral part of the parietal wall. So in conclusion, the female genital tract crucial role in rectal surgeries because of embryological connection, anatomical proximity to the rectal wall, and functional interdependence between the vaginal wall and the rectal wall. A deep understanding of this relationship can enhance our surgical precision and reduces complications, improves long-term quality of life for patients. Thank you. I'll be happy to take any questions.
We'll have the discussers presentation, and then we'll have.
Yes, sir.
So that was a, is it okay? That was a very comprehensive presentation on lower female genital tract. And we would just like to highlight a few points. My colleague, Dr. Priyanka, is going to present, and then I will like to discuss a few points after that.
While they are uploading, Yashwant, any tips for preoperative consent as far as possible removal of ovaries, uterus, any special?
Sir, like already I mentioned, if there is any suspicion of syndromic presentations, if there is an involvement of ovaries, or if it is a atrophied uterus, or if there is any high chances that patient having symptoms of vaginal atrophy, like use of any intrauterine devices, where there is high index of suspicion of having a rectovaginal fistula, which can be a very morbid condition, then the patient can be counseled for simultaneous hysterectomy along with oophorectomy in these patients.
Sorry, I didn't get your point about intrauterine devices. What was that?
If there is any intrauterine devices, the chances of having uterine injuries because of fibrosis or any dislodgement if it has happened while performing rectal surgeries.
So I think premenopausal and postmenopausal patients have to be dealt differently when we are planning surgery, for at least keeping in mind the preservation of ovarian function or fertility preservation. So if the woman has completed the family, then of course preservation of ovarian function is the main thing. Otherwise, recently I would like to share that I had a patient who was CA rectum and referred for ovarian preservation. But we have also to keep in mind the planned adjuvant treatment. So she was, when I asked the primary surgeon, she was for CTRT. In that case, ovarian transposition also might not help us because CT is a systemic treatment. So then we have to have a proper maybe, ovarian stimulation and ova freezing. So there are two different types of treatments that have to be, and then Lynch syndrome, etc., like you said, the HNPCC and the other hereditary syndromes, they have to be kept in mind also while treating the younger women, basically. So we have to have the MSI panel to see whether we need to do prophylactic cancer, risk-reducing surgery in them, or leave it for later till they complete their family. That is also.
Ma'am, since most of our audience is general surgeons or GI surgeons, can you please elaborate on the technical steps of this ovarian transposition? Because, I mean, most places a gynecologist help would be available, but in case we have to do it ourselves, how do we do it?
So in that case, the basic thing is we have to basically, first of all, we have to ensure that the ovaries are healthy for transposition. And then we have to keep in mind that we have to keep the blood supply intact as far as possible. Because if you denude the ovaries so much that they as such become dysfunctional, then there is no use of transposition. So we have to keep the meso-ovarian tissue intact as far as possible. And then along with the mobilizing the infundibulopelvic, we have to take them out of the pelvic brim as high as possible at times people do take it up to the near the liver, but then maybe sometimes the stretch or kinking is so much that it's not practically advisable. So as high as possible above the pelvic brim, so that they are out of the range of scatter radiations also. So that is the thing. And then we make a tunnel in the peritoneal wall and clip the ovaries there, so that later on they can be identified for further management.
I just wanted to add
Yeah.
a point what you
Yashwant,
sorry,
please.
sorry. Like we have seen, in our center, we are seeing more of young patients of rectal malignancies. Though radiation or chemotherapy can cause infertility, even a surgical uh, complication can, because of obstructions of fallopian tubes, post surgery can lead to infertility. So generally here we do a MSI testing for all younger patients and all the patients of malignancies, colorectal malignancies. And if it is younger, in case of fertility is prime importance for the patient, we generally ask for ovarian preservation in these patients, because sometimes surgery itself can cause infertility in these patients because of injury of nerves or even for the obstructive pathology.
So in case, even if if she is at high risk, then even if she is not at high risk, we would advise to remove at least the fallopian tubes, because nowadays fallopian tubes are said to be the origin of many of the high-grade serous ovarian malignancies. So that, yeah.
Regarding the chemoradiation, since we're seeing a lot of young female patients with CA rectum and chemoradiotherapy does affect the fertility, then would you propose the ovarian transposition even before we start the radiotherapy for the rectum?
Yeah, definitely. Definitely, but then you have to have the ovum freezing for those.
That is because that when the cost is an issue for our patients, then there's
when cost is an issue, then ideal treatments are not possible.
Give an option of
Yeah,
ovarian
offer तो आपको करना ही चाहिए. You should offer them all.
We definitely offer, but otherwise, if
the
ovarian
transposition can be done before starting CTRT.
That can be debated, because CT can lead to. Sorry.
There's no recommendation on this about the translation of ovaries for CA rectum.
No recommendation.
Very clearly. Ovarian preservation should be done.
Yeah, that is for hormonal milieu basically. And ovaries are said to secrete, even if estrogens go down, they are said to secrete a small amount of androgens. So that quality of life, libido, etc. can be, maintained. We are not saying they are maintained, they can be. So that is the best that we can offer these females.
No, but let's be clear about it. So CA rectum, if we know that we are going to give radiotherapy, is ovarian transposition recommended? Should it be done?
Yes, if only radiotherapy, yes. If CTRT.
But most of the CA rectum today will receive pre-operative radiation. So do we do a surgery only for ovarian transposition?
You can add.
Yes, Yashwant.
Sir,
should.
Yes, sir. There is no consensus regarding the preoperative transposition of fixation of ovaries, because there are studies which shows that on long term, up to 50 to 60% patients may not achieve. They cannot conceive even if the patient has undergone ovarian transposition.
So that was the point. It is not only about conception, it is about maintaining a better quality of life by preserving the hormonal milieu as much as possible.
No, but this means an extra surgical procedure just for ovarian transposition.
So that can, usually it is done laparoscopically now.
Whatever. But no, chemotherapy transposition will not help. That's what Dr. Anu is saying. If we have to give chemotherapy, then it is ovum preservation. Yeah, so that is what I was coming to, that most patients today of CA rectum will receive, very few patients will receive radiotherapy alone. That will be only if we are giving short course radiotherapy. Yeah. Then transposition will help. Yeah. But my question is, as Dr. Nitin is saying, it is still not a recommendation in the GI oncology practice. Okay. That is the one. Second, as Naina is saying, that most patients will receive both chemo and radiotherapy. In that case, transposition is not helpful.
It is not
that case, you have to go for ovum preservation.
Yes.
Which...
Anybody has done ovarian transposition as a routine?
I have done in CS cervix, not in G, obviously not in GI.
I have not seen anyone doing transposition for preemptively.
Then another option is also there, so we can down-regulate the ovaries by giving GnRH analogs. So what we do in the pubertal, the young patients with germ cell tumors, or in which we have to give adjuvant chemotherapy, sometimes BP. So in that case, we give the GnRH analogs, and so to down-regulate so that the oocytes they don't get mature and.
This is commonly practiced
yes,
what you said.
we-
Hyperstimulation of the ovaries.
Okay, let's have your presentation,
Yes.
and then if time permits,
Yeah.
I have few more.
So, as already been discussed in all the prior slides, I'll just be covering the few points, basically the vasculature and the nervous supply of the pelvis. So, this is my first slide, just to show the anatomy of the pelvic floor. As Dr. Yashwant said, basically it is the levator array muscle, which is consisting of pubococcygeus, iliococcygeus, and the puborectalis muscles, which can I have the cursor please in this? इसमें cursor आ जाएगा तो चलेगा. So the pelvic floor is comprising of the levator ani muscle. So all the three muscles makes the pelvic floor, in which all the orifices are present. And so these are the basic pelvic supportive tissues. We have anterior supportive tissue, middle supportive tissue, and the posterior supportive tissue. So anterizing of the vesico-uterine ligament, anterior and posterior. The lateral is, or the middle supportive tissue comprises of the cardinal ligament, and which carries with them the pelvic splanchnic nerves, and it connects the uterus with the lateral pelvic wall. And then the posterior supportive tissue, which is present between basically the uterus and the rectum. So these are the uterosacral ligaments, and it involves the hypogastric nerve, basically is present there, and the rectovaginal ligament. So the vascular anatomy, when we dissect the retroperitoneum, all the vessels present, main vessels are present, starting from the bifurcation of the common iliac artery, which starts at the sacral promontory, and it is the external iliac artery, the internal iliac artery, and the ureter goes in the medial fold. Then comes the psoas major muscle is the lateralmost, the external iliac artery, which gives rise to the inferior epigastric artery, and it goes into the anterior abdominal wall, which is important at the time of the laparoscopic port insertion, because sometimes it can lead to the hematoma formation. So we have to avoid this vessel. So this is the anatomy, just the one branch which is given by the external iliac artery in the pelvis, and then the down below goes the external iliac vein. This is the obturator nerve, and below lies the obturator vessel, which is the only lateral branch given by the internal iliac artery in the pelvis. Otherwise, all the branches of internal iliac artery are the medial ones, like uterine artery and the superior vesical artery. Then this is the relationship of the ureter and the internal iliac artery. This is the uterine artery, which is coming from the internal iliac artery, and the superior vesical artery, as I told. Now, most important thing at the time of the dissection, especially in radical hysterectomy, is the nervous supply. The pelvic structures are supplied by autonomic nervous system, as told by Dr. Yashwant. Inferior hypogastric plexus, the nerve, and the pelvic splanchnic nerves, mainly the sympathetic and the parasympathetic respectively. These fibers merge and form the inferior hypogastric plexus, which supplies both the uterus and the urinary bladder. And they form a cross-shaped plexus, which is known as inferior hypogastric plexus. Basically, it is a cross-shaped plexus, and when we do the nerve sparing radical hysterectomy, it gets converted into a T-shaped one, which is composed of hypogastric nerve, the pelvic splanchnic nerve, and the bladder branch. Basically, the aim is to preserve the bladder branch, sparing the urinary and the sexual function. So this is the goal of nerve sparing radical hysterectomy. These are the pelvic autonomic nerves, the parasympathetic supply and the sympathetic supply. So as I told, this is the plexus, which is a cross shaped. There is a uterine branch, there is a bladder branch, which we have to preserve, and we have to convert it into a T-shaped plexus. Then there are the most important are the spaces of the pelvis, which are avascular spaces, and for doing a radical hysterectomy, lymph node dissection, we have to dissect in these spaces. So the bilateral spaces are the pararectal space and the paravesical space, and the unilateral or midline spaces are prevesical space, rectovaginal space, and the retrorectal or presacral spaces. This is the diagram showing the paravesical space. between the medial to the basically external iliac artery. I'm not going into the details of the boundaries, just to have a general idea. So this is the let's go pararectal space, which is the lateral to the medial to the ureter, and the lateral to the ureter, and the Okabayashi space is medial to the ureter. So this is the paravesical space, the above one, and the below is the left pararectal space. There is another space, prevesical space, which lies between the bladder and the anterior abdominal wall, which communicates with the paravesical spaces on both sides, and it is enclosed laterally by the lateral umbilical ligament. It carries an importance in the urological surgeries, basically in the management of SUI and the sling surgeries, and also in anterior exenteration in some certain localized recurrent cervical cancers. This is the posterior rectovaginal space, which is between the uterus and the rectum. And then we have to dissect the denonvillous fascia. Dissection is performed between the two layers, which creates an avascular plane. And it completely separates the uterus from the rectum. And another last space is retrorectal or the presacral space, which is again, it lies behind the rectum, covered by the mesorectum anteriorly and the Waldeia fascia posteriorly. The presacral veins lie in this space posterior to the Waldeia fascia. It can lead to bleeding if these veins are injured. So the dissection has to be very careful. So the retrorectal space is useful in posterior exenteration or complete mesocolic excision of the involved rectum, like I think TMEs, which total mesorectal dissections. And in also we have to be careful in deep infiltrating endometriosis involving the rectum, sacrocolpopexy, and the presacral neurectomy. That's it. Thank you.
So one more point I wanted, Yashwant. So you said that uterine stitch to fix it to the anterior parietes, but that becomes a fixed retraction.
Yes, sir.
You can't change it unless you take another stitch. So would you prefer a uterine sound? But then, of course, you need an assistant.
Yes, sir. We need assistant. Even sometimes we use a fan retractor, but we need extra port or assistant for that.
Not an internal uterine sound.
So we don't have in our
uterine manipulators are there, so they can be used. We usually use in gynae for uterine retraction.
I'll take that stitch and I'll
was
keep it dynamic. I will not fix it to the parietal wall. I'll just keep a artery to that, and so that it can be manipulated.
there was one
So-
thing. Yes.
Yes. You are saying you take a stitch, but don't fix it to the parietes.
Yes, sir.
Okay. Yes.
Dr. Yashwant, you said the fat belongs to the bladder and the vagina. I mean, I am not sure because the vagina is denuded of fat.
I mean, not the complete fat that it is basically a vascular thing which we have to be.
So fat belongs to either the bladder or the rectum. This is what we have.
Yeah, the classic dictum was regarding the bladder itself.
Yeah.
We are missing on that important message what he's saying. When the surgeons, as a surgeon, we do in rectum, we don't want the fat to be with the rectum. We believe that it has to be left with the vagina. When you are doing it, you don't want to go into the rectum, so you believe it is the rectum. So that the concept is different.
To clarify how the fat will go with the vagina. Okay, that's
so, as far as the anatomy is concerned.
Yes, sir.
Do you prefer to pack the vagina before surgery?
Before what?
And what is optimal? Your hysterectomy when you are doing that. Okay. And what is optimal packing? Do you prefer packing or do you not prefer packing?
There are two things, sir. If we think that the uterus is very small, the pelvis is very deep, then packing will help because it will lift it up. But otherwise, generally in gynec surgeries and gynec onco surgeries, we do not. But yes, in Verdheims and all, at times it will give you a little bit of extra traction and counter traction. So during that time, we can do.
Basically, some surgeons pack it so that the bladder dissection, because
that is what
radical hysterectomies. But it depends on the expertise and experience, basically.
I generally don't do it for large uteri and shallow pelvis.
Surenji, there is a comment, I think, chat दिखाई है. Yeah, Dr. Subramanyeshwar.
Ovarian transposition is commented.
Sir, I think we need to get a few things clear.
Yes.
Young rectal cancer is not uncommon, sir. With your experience, you would have seen. So women with young rectal cancer, now it's a policy in the institute that they are sent to surgeon for transposition, because menopause at that young age has multiple problems. Radiation menopause is rapid, and most of these patients have serious symptoms apart from the fight that they are against a cancer. This is there, and then and these are curable cancers. They have a higher chance of dying of cardiovascular and skeletal events later on. So I think it's important. It's a simple technique, and it's a 3-port technique. So we do it on a regular basis. And what is in the literature is there is something called utero-ovarian complex transposition. The uterus is mobilized, and it survives on the infundibulopelvic ligament vessels, and it is transposed a little above the umbilicus, at the umbilicus, and then you irradiate and bring it back and anastomose. And pregnancies have been reported in such an exercise. We have not done it. We could not actually find a patient to do it. Technically, it's not very difficult, but Brazilian groups do it. I've actually posted a link to the publication. So all this is done to preserve both fertility, but transposition is purely for hormonal function, and I think hormonal function is very, very important, sir. When you are looking at cure, I think
What we were discussing earlier was that if the patient is going to receive both chemotherapy and radiotherapy, then transposition may not be of help.
so, but not all chemotherapy is induced by permanent menopause, sir. They come back.
So in that case, you can do ovum suppression, and then after the chemo
Yes.
starts,
Yes.
stops, it can be released again.
Yes, sir.
The other issue I want to discuss with both GI surgeons and gynecologists is endometriosis. Now, a known patient with endometriosis obviously will not come to us, it will go to you. But we may encounter an unexpected endometriosis where patient has presented, say, with subacute or acute intestinal obstruction. We go in, we think these are adhesions. So for a GI surgical oncologist, what tips you can give to us that when should we think that it could be endometriosis, and then what precautions or what steps we need to take? And maybe you can also.
Endometriosis is very evident by its nature. When you open it, it will
Evident to you, but not to us.
Sir, it will release an anchovy sauce like secretion. So that brown chocolate colored secretion is the one thing that sometimes there are whitish patches also, but they're very early. So I don't think surgeons are going to encounter them as such, because they usually come to gynecologists. So if you have a mass, endometriotic mass, it will be very evident by the color of its secretion. Yes, endometriosis can be a very difficult thing because the planes are not as good as in malignancy. So then rectal invasion, bladder invasion, all these are there. Even scar endometriosis are very common nowadays. So all these things have to be kept in mind, and that is the only option available. And medical treatments are there, but then after resection, they will be given. So your view, Dr. Subramanyeshwar?
Anything on endometriosis, Subramanyeshwar or Yashwant?
I don't have large experience, sir. I don't have large experience because ours is a standalone cancer center. But we keep seeing patients with not that small endometriosis, but large masses who get diagnosed, and there is a worry. There is an index of one-stage surgery. They keep coming. One thing, sir, that I would want to tell the younger people is it's so much more difficult to do endometriotic surgery than cancer surgery. Cancer surgeries, because there is blood in it, it produces such severe desmoplasia, and the tissues can be rock hard, and it can really test your skills and knowledge also. So I think the best step to choose endometriosis surgery. Yes.
So the
I had
endometriosis,
one
if it is
patient
limited to the pelvis, then I think it can be dealt by us. But if endometriosis is so severe that it is, going to the extent of the intestines and the large, then of course we are also going to call you guys only. So endometriosis is really bad.
Yashwant, you were saying something?
I had one patient where the laparoscopy was converted to open because of endometriosis.
Yeah,
in
definitely.
Yeah, bigger problem with endometriosis is whatever you may resect, there is very high chance of
Recurrence,
That's
exactly.
fair, so you have to.
called an R0, R1.
Yeah.
Something, but with endometriosis, you don't have a term R0 because you don't know where you have left the things.
To cover it with medical, such
Yeah.
big endometriotic, you have to give medical management for endometriosis.
About ovarian retransposition, actually there was a lot of discussion few years back, till 5 years, 7 years back, when we used to go to the conferences. But gradually why it is coming down is that the people, most of the oncosurgeons and the surgeons who are dealing with rectal malignancies, they realize that actually this is required in young patients, and they have seen the young patients usually have a very aggressive malignancy, they will not survive for long. So that is and older patients don't need it. So they may not need it. So this has gone out of a ritual as a standard to do it in all the patients nowadays.
Maybe with CA rectum, but in gynec malignancies, we do transpositions only.
I think I'll completely beg to differ. I'll show our own data where patients do well. It's not a young age that decides anything, sir. It's the higher grade tumors that manifest in a young age because they grow so rapidly that that it occurs in a younger patient. But there are survivors, and even if you have 5 out of 100 who are surviving, I think it's good to keep them in premenopausal range. I think it's important.
I think as GI surgeons and GI surgical oncologists, we should know that that option is there. We should
Yes.
probably give that option to the patient and then maybe take a call.
True, sir. I think
So
well said.
if there are no other comments on this session, I think I will buy 5 minutes from this session because we started late. So thank you, Yashwant. Thank you. And thank you, Dr. Anupatni and Dr. Priyanka for joining us for this session. You are most welcome to listen to the stomach, but if you want to leave, thank you. Thank you very much. So the next is surgical anatomy of the stomach as an esophageal conduit. And we have with us Dr. Hamza Wani, who has recently shifted from the Government Medical College in Srinagar to Paras Hospital in Srinagar. Hamza. And the discussers are Dr. Nag. Dr. Nag, you are there online? Dr. Nag is the Chief of Surgical Gastroenterology at GB Pant Hospital. And we have...
Yes, sir, good morning.
Morning. And we have Dr. Subhash Mishra here. Subhash, your current affiliation, sorry. Narayana Hospital, Jaipur. Yeah. Subhash, maybe you can come here.
Start, sir?
Yes, please.
Good afternoon. We were expecting to have this session in the morning, so thank you for having me, sir. So my topic is surgical anatomy of the stomach as an esophageal conduit. So we'll be focusing on the per se anatomy of the stomach that is important in the construction of the conduit and also the anatomical consideration that we need to have for construction of a successful conduit once it's made. So as GI surgeons, we always consider the esophagus as a not so friendly neighbor because it lives just across the diaphragm in the chest. And whenever we need to go in there, we encounter the complications that are so common with esophageal surgery. And why is it so? Because the surgical management of esophageal diseases is still the mainstay of treatment for a number of diseases, be it an end-stage benign esophageal disease, obviously for malignant diseases, and also situations like esophageal perforation and caustic injury to the esophagus. And despite evolution over the last 2 centuries, esophageal surgery has come riddled with its own set of postoperative complications that still remain quite high. Also, once the conduit is constructed, we have the problem of loss of quality of life, which might be due to loss of reservoir or impaired swallowing. To mitigate most of these problems, we have come up with a number of procedures that have combined minimally invasive robotic surgery as laparoscopy and also hybrid procedures combining the both. So just a brief history of this, since we've been replacing the esophagus. It started in 1913 with Franz Torek in New York. He placed an extracorporeal rubber tube from a cervical esophagostomy to a gastrostomy. You can imagine what that would have looked like. In 1920, esophageal stricture bypass was done by means of a gastric pull-up, and the stomach was placed subcutaneously. The first intrathoracic esophagogastric anastomosis was made in 1933. And the early iterations of the greater curvature-based gastric tubes, as we practice it today, it started in the early 50s. Like I said before, we have combined all these procedures into minimally invasive now. So when we talk about restoration of bowel continuity, since esophagus is part of the bowel, whenever in the abdomen there is a resection of any part of the bowel, we resect it. The ends that need to come together, they lie in the same place with its vessels, nerve supply, and lymphatic drainage. Like in the small bowel, we resect and we bring it together, it's right there. Even if we resect the stomach, we do a subtotal gastrectomy, bring the jejunum up, it's right there with its blood supply. Even when we are dealing with the hepatobiliary system, reconstruction of the biliary tract, we get the jejunum, which is right there and with this blood supply coming up. But the problem with the esophagus is that it lives in the chest and the conduit needs to come from the abdomen. And not just the conduit, it needs to come with everything, the blood supply, the venous drainage, and also the nerve supply. And it has to be an ideal conduit. That means it has to be living viscous. It has to be free from intrinsic diseases. It has to have an adequate blood supply, which we'll be talking about a lot because blood supply is the key in this. And also we need to understand the number of anastomoses that we're going to make in the choice of the conduit. So here historically, we've had three conduits that we've been dealing with. One is the stomach. Then there is the colon, that could be the right, the left, or the middle colon as the choice and the situation demands. And then there is the perennial rescuer, the jejunal loop, that can be used as a supercharged graft as well. Now, since we're talking about the stomach, is it really the best suited conduit for replacement of the esophagus? I think so. What makes it desirable is because, number one, it has robust vascularity. That means it has a reliable arcade-based blood supply. We can generate a sufficient length out of it. It can reach the pharynx without tension in most of the cases. It is technically simple. Like I said before, a single anastomosis will do as compared to the others. And it is efficacious functionally because it provides a reliable digestive function without all physiological alterations. And the primary goal to create a conduit which ensures good healing is provided well by the stomach. Like I said, we'll be talking about the vascularity. The blood supply of the stomach is the cornerstone for building a successful conduit. Again, the stomach here is a little different from the rest of the bowel because the rest of the bowel usually has a mesenteric and an anti-mesenteric border. The stomach is supplied as in an arcade fashion on both the lesser and the greater curvatures. So in its most common form, the celiac axis gives the common hepatic artery on one side, the sphenic artery, and then the left gastric artery move towards the left. And then it curves along the lesser curvature towards the right and forms an arcade with the right gastric artery, which comes from the other side, from either the proper hepatic or the common hepatic artery itself. When we talk about the greater curvature, which is the most important here, since our conduit is going to be based on the right gastroepiploic artery, it forms a continuation of the gastroduodenal artery and the arcade along the greater curvature, and the left gastroepiploic artery coming from the sphenic artery on the left side. And then there are the short gastrics along the greater curvature proximally as well. Now, this view was important because once we make the conduit, this is how the stomach is going to be placed. As you can see, the pedicle of the right gastroepiploic artery is going to supply the conduit from right to left of the patient, and the arcades that anastomose with it within the mural network of the stomach is going to go from right gastroepiploid to the left gastroepiploid and then the intramural vascular plexus. A little bit about the venous drainage. The veins along the lesser curvature are the left and the right gastric veins. They drain into the portal vein. The short gastrics and the left gastroepiploic, they drain into the splenic vein, and the right gastric junction, which is the site of portocaval anastomosis. So these are all things that we need to keep in mind while constructing a conduit. We'll be connecting and disconnecting all of these connections. So when we plan a gastric conduit, it might be for various indications. It might be conditions, might be malignancy or benign, or even a trauma situation. Do we really need to pre-plan the conduit? We say that the planning is of critical importance because a multidisciplinary assessment of the conduit needs to be done that is preceded by a detailed history of any previous procedures or interventions. Why? Because sometimes patient might have history of a bleeding ulcer and the gastroduodenal artery might have been embolized or even ligated. Patient might have had an endoscopic intervention for an ulcer in the stomach, which might preclude the construction of a successful conduit. The cornerstone of preoperative planning of conduit is a multi-detector CT and CT angio with reconstruction, as well as an endoscopic assessment, which is mandatory to ensure a disease-free conduit within the mucosal network, because sometimes there are AV malformations and mucosal diseases which might not be so apparent on cross-sectional imaging. Like I said before, a critical finding may actually preclude the usage of a gastric conduit. So this is the Mitchell's classification that tells us about the anomalies in and around the celiac axis. I have mentioned the 6 types which are relevant in this case. The point to understand here is the origin of the left gastric artery, because we need to identify and ligate the left gastric artery as close to the origin as possible. So the type 1 is the most common one, that is the trifecta. Type 2, the celiac axis forms the hepatosplenic trunk with the common hepatic and the splenic artery, and the left gastric is directly from the aorta. And if you look at the type 4, there the left gastric axis along with the common hepatic artery, the hepaticogastric trunk. So these are the various anomalies that we need to keep in mind. And a preoperative multi-detector CT and CT angio gives us a good idea about these vascular anomalies. So these are a few more examples. If you can see on the left, here there is an accessory left hepatic artery that is coming from the left gastric artery. Although there is a left hepatic artery that is coming from the proper hepatic artery here, there might be an entirely replaced left hepatic artery that might be the only branch coming from the left gastric artery. Again, identification and taking care of this vessel is of utmost importance. On the right, you can see there's a median arcuate ligament syndrome, compression of the celiac axis right at the origin. Once we mobilize the conduit, since the blood supply is coming from the celiac trunk, the vasculature might be compromised. So again, identifying and realizing what we need to do intraoperatively, maybe we need to use an alternative conduit. This preoperative planning goes a long way in deciding that. Now, moving on to the veins. One of the most important veins that we need to consider while we are constructing a gastric conduit is the left gastric vein. It is one of the largest veins in the area. And the problem with this is that the normal anatomy of the left gastric vein is that it runs behind the common hepatic artery. But in some cases, the most common anomaly is that it might actually be running in front of the common hepatic artery and even the splenic artery. So here, when we're doing the suprapancreatic dissection, there is a great chance of injury to this vessel. The problem with that is that it bleeds a lot. And we have seen that literature has shown us that intraoperative blood loss is a negative predictive factor in how well the conduit does intra and postoperatively. So here you can see this large left gastric vein coming in front and has been clipped and identified, clipped and divided between 2 clips along with the left gastric artery. So as far as the vasculature is concerned, those are the concerns that we need to see in the arteries and the veins. But what about the structure of the conduit? The 2 main concerns in the structure of the conduit is how long should it be and how wide should it be. Length is important because we need to bridge the gap, and width because it is based on a single vascular pedicle and an island flap. The width of the tube becomes of primary importance over there. So if we make a conduit that is too wide, so let's say it's more than 6 centimeters, it acts as a reservoir leading to significant delayed emptying. And if it is too narrow, there is chance of ischemia at the tip. How do we know that the conduit is good enough? We basically identified that if we have a 2 to 3 centimeter redundancy at the anastomotic site, the length is good enough. And then stapling will come to that after this. So normally we make 3 types of conduits, type 1, type 2, and type 3. Type 1 is the narrow gastric tube. We choose this when we need to make an anastomosis in the cervix, in the cervical area or in the upper mediastinum. The type 2 is a J-shaped tube. Again, a long tube for upper mediastinal anastomosis. And type 3 is the whole gastric tube for lower mediastinal anastomosis. once we do a laparoscopic dissection, the first step is always to open the gastrocolic omentum, then open the pars flaccida at the top, take care of the left gastric artery, divide the short gastrics, and then evert it. And then we do the stapling. In the stapling, what we do is we basically start from a point 4 centimeters from the pylorus, angle the 45 millimeter staple load, go towards the greater curvature. We're basically aiming for a width of the tube of 4 to 5 centimeters. And from here, we go with 60 mm loads parallel to the greater curvature up to the angle of His, and the proximal stomach can be seen at the top. Why I said this is basically a tube that we need to take into the into the neck. So the width of 3 to 5 centimeters is good. The rationale behind this is that the supply from the gastroepiploic artery is good up to 3 to 5 centimeters. And also, as we have seen in literature, large meta-analysis and analysis of retrospective data has shown that the leak rate, the stricture rate, and the delayed gastric emptying of the narrow and the wide and the whole stomach tube is almost similar. But the issue is always with the reflux. Across the board, the reflux in the whole stomach conduit is higher than that of the narrow gastric tube. Now, this is a wonderful study because since we're talking about anatomy, this was done in the early 90s in Germany. What they did was they studied in cadaveric subjects. They they constructed a gastric tube and then they infused the vessels with a fast setting, cold setting resin. The size of that was 120 micrometers. And they reconstructed the vasculature of the tube once it is constructed. What they found was, as we know that the main supply of the tube comes from the right gastroepiploic artery. And if we divide the whole tube into 100%, the proximal 60%, the supply is primarily from the pedicle of the right gastroepiploic artery. The 20% following that comes from the connections between the remnant of the left gastroepiploic and the right gastroepiploic. And the final 20%, that is the tip of the iceberg we were talking about. That supply is basically from within the mural network of the gastric wall. Now, in this study, once they did corrosion of the specimen, they could not visualize the final 20%. That was because of the size of the resin was 120 micrometer and it did not percolate into the submucosal and the mucosal plexuses. And since then, the studies that we have done with angiography and fluorescence, this has been confirmed. And these are the casts. The one on the left is the arterial cast. You can see that the supply is coming from the epiploics at number 3. That is the junction of the right and the left gastroepiploic. And just at the tip, that's where the arterial supply is disappearing. That's where the submucosal plexus is coming into play. So once we make the conduit, this is what it looks like. Like I said before, if you superimpose these two images, you can actually see how the right gastroepiploic works. But on visualizing, the color looks absolutely fine at the top. The second question is, where from do we need to take the conduit? So 3 routes of transposition have been established. There is a subcutaneous route, which is very rarely used. There is the retrosternal route and also the posterior mediastinal route. These are just not surgeon choices. These are determined by the kind of procedure that we're doing. 3 major procedures: McEwen, Ivor-Lewis, and the transhiatal esophagectomies. In the McEwen and the transhiatal esophagectomies, the anastomosis is in the neck, so the choice is out. In the Ivor-Lewis, we need to move the conduit into the chest. So in McEwen esophagectomy, where we need to move the conduit into the neck, we can choose either a retrosternal route or a posterior mediastinal route. But in Ivor-Lewis, it is already decided that we need to go via the posterior mediastinal route. When we look at the literature regarding the route of transposition of the conduit, the RCTs and meta-analysis high quality data have shown that no statistically significant difference in anastomotic leak in comparing retrosternal and the posterior mediastinal route. The only difference is that whether the posterior mediastinal is available to us or not. Because in a situation of a corrosive esophageal injury or a post-perforation esophagus and a posterior mediastinum that has been irradiated preoperatively, those give us environments that are not so conducive to use that route as a transposition. So summarizing these three, posterior mediastinal route, the advantage is it is shortest and the most direct. Disadvantages, like I said, that there is risk in case of recurrent tumor or post-radiation, or if there is a sepsis in that area that precludes using this route. Retrosternal, it avoids a contaminated or irradiated field, but it's a longer route. There's a sharper angulation at the thoracic inlet. Subcutaneous is absolutely rarely used. It is reserved for high-risk cases, as it allows external monitoring and very prone to functional issues. So once we have constructed this tube, we have understood that at the time of construction, the viability is there. Do we really need to assess the perfusion again? So objective and reliable information about perfusion can guide the surgeon to decide the appropriate anastomotic site. Number of things have been tested over the years, like laser Doppler flowmetry. And now near infrared fluorescence with ICG has emerged as a valuable tool across the board, both for minimally invasive and open surgery. Over the years, these are the things that have been used. And now ICG over the past around 25 years has come in a big way. And we have also started to use it. And it guides the point of anastomosis in the chest or in the neck. So this is the representative image showing the ICG flow in the normal mode on the left and the overlapping mode on the right, which has helped us tremendously. And we have done a few conduit revisions also because of poor perfusion in the tip assessed on this. Now, what in case perfusion is insufficient? We do an ICG flowmetry and the perfusion is insufficient at the anastomotic site. We can rescue a Cocker maneuver can give us about 2 centimeter reduction in the gastric conduit length. Pedunculated gastric tube has also been recommended, where we transect the duodenum and based still on the right gastrophilic artery can give us a length of 15 centimeters. And also there is the option of supercharging the short gastric vessels. I don't know, we have no experience with this, but the supply comes from the upper mediastinal and cervical arteries and veins. And this is what it looks like. Again, a representative image of the pedunculated gastric tube, and the stomach is connected to the bowel by a Roux-en-Y jejunal loop. Now, another issue with the conduit is what sort of anastomotic technique should be done. A hand-sewn technique, a circular or a linear stapling techniques have been tried. I'll just rush through this quickly because time does not permit. So this is an example of an end-to-end anastomosis using an Orville, using a circular stapling technique. So then this is what we use very frequently, the side-to-side stapled technique or the esophagogastrostomy. And this is the very popular triangulating stapling technique, again using the staplers and then suture guided stapling technique transversely. The preference in, but overall having higher stricture rates in literature. Now, once the conduit is done, we need to protect it. We always recommend, there's a wonderful paper that has come from CMC Vellore that has been published this year only. That ICG angiography should be done both before and after mobilization of the conduit. That has helped them to identify insufficient flow post-mobilization in almost half of their cases. And they came to the conclusion that assessing perfusion at both stages of the operation is crucial to identifying and addressing perfusion-related issues. The question of pyloric drainage procedure is always there. Pyloromyotomy or pyloroplasty can be done because there is a pylorospasm. It is debatable but widely practiced. We prefer to do an endoscopic dilatation on table with the help of our gastroenterology colleagues. With the graduated balloons, we break the pylorus. We don't do a formal surgical pyloroplasty. And there was also a question of ischemic preconditioning where the left gastric artery was ligated before we made the conduit. But then again, this has not come to not much benefit has been seen. These are just the representative of how the pylorus can be defunctioned. The review of the pylorus drainage has shown a non-significant trend towards this, but so just summarizing, the right gastrophilic artery is the cornerstone of the gastric conduit. Meticulous mobilization and geometry are required to create a conduit that is both tension-free and well perfused. Majority of devastating leaks have their roots in disrupted vascular anatomy. And ICG fluorescence angiography has come up as a powerful tool to objectively assess perfusion and guide safer anastomosis. Thank you very much.
Sorry, I forgot to mention that Dr. Pankaj Singh, who's the Chief of Anatomy with us at Mahatma Gandhi Medical College, is also a discusser. Actually, Subhash is a discusser for the next talk, but anyway, yeah. So, Dr. Nag first, online. Dr. Nag?
Yes, sir. Actually, I don't have any presentation. I think Dr. Pankaj should go and then we can discuss on that.
No, in case you want to make any comments or anything else, any tips you would like to give to young surgeons in the audience?
Actually, I think Dr. Hamza has this thing covered it all. Only thing I think we have to prepare a patient properly in advance, and we should be careful about the abnormal anatomies, like especially left hepatic artery or replaced hepatic artery, left hepatic artery, and we should try to preserve them. Celiac artery abnormalities should also be kept in mind. In some cases, posterior gastric artery, actually prominent artery, arises from the splenic artery that may be contributing a lot to the this thing. So that we should also keep in mind. And regarding venous anomalies, I think they are more pertinent to D2 gastrectomy, because in that we are doing lymphadenectomy. In gastric conduit, usually unless we are doing extensive lymphadenectomy, they are not at risk if they are following basic principles. And we should be careful about the contraindication, like if vascular anomalies are there or stomach is not available. In some cases, if it is strictured, and in some cases, tumor is quite extensive and margins are not available in malignancy cases, then we should opt other options. And this intraoperative difficulties we already mentioned. We should always reassess the wherever there is confusion about the distinct vascularity, we should reassess and we should take proper action. If needed, we can supercharge with the help of maybe CVTS colleague or plastic surgery colleagues. That's all. I think it was covered well. Anything that if anybody wants, then I can cover.
Dr. Pankaj?
First and foremost, I would like to thank Dr. V.K. Kapoor for giving me this opportunity to be the discusser. It's an absolute honor to be sitting beside some of the best surgeons. Being an anatomist, I'd like to give an anatomical perspective to things the way we anatomists look at it. If you just look at the logical sequence of things, right from why stomach, as sir was saying, was used as a conduit, why is it an ideal conduit to the mobilization of the stomach or the reshaping of it and the anastomosis. At every step you feel that the anatomy part seems to be dictating the process. And just to elaborate further on it, Dr. Hamza very well started off that why stomach is a very, very good conduit. And if you look at the anatomy of the stomach, the vascularity of it, it has a very, very robust and a very reliable vasculature that's there. And along with it, some certain other points are there. That is the only one where we see that we don't have as many anastomosis as we have in the jejunum and in the colon. Even further, if we'll take a closer look at the wall of the stomach, it's very thick and resilient. So that in itself is good for stapling, I suppose, and it prevents from ischemia. The length of the stomach along the greater curvature, around 25 to 30 centimeters, that's an ideal length for a conduit to be there. Further looking at the anatomy of the stomach, being its close proximity to the posterior mediastinum, which is the natural highway through which the esophagus passes. So that makes it easier to be pulled up. So at every point you feel that anatomy should not just be remembered, but also respected. Even the mobilization part, when we come to it, while forming a conduit, we first cut open through the gastrocolic omentum to enter into the lesser sac. Later, we free up the fundus by cutting the short gastric vessels, and then we free up the lesser curvature by cutting the left gastric and the left gastroepiploic artery and all those structures. So, anatomy keep revisiting you. One important point that we need to remember. I'm sorry if I'm just going into the domain of the surgeons, but the important point is a very important no-touch vascular zone, that is the right gastroepiploic artery, because sometimes due to inadvertent cauterization, we might damage that area, or skeletonization, if I may use a term from surgery. We sometimes can damage that area because the entire load, the lifeline of the blood supply, is taken care of by the right gastroepiploic artery and the submucosal supply that it provides along with it. So that's a very important point that we need to take care of. And for an ideal conduit, as the dictum goes, that a good conduit is one that is long, narrow, straight, and pink. So, sir, very well told how we staple along the greater curvature to make a 4 to 5 centimeter width conduit. So all these points, I just wanted, sir, a few points I wanted to know. How different is the length when we take a route through the posterior mediastinum, or it's the retrosternal route?
So the most physiological route remains the posterior mediastinum. But
Shortest also.
yes, it is the shortest and the most physiological, and the most tension-free anastomosis can be constructed from there. The only situations where the posterior mediastinum creates a problem is when there is a disease like a corrosive injury to the esophagus, which has been there for a long time, lot of fibrosis, or there has been esophageal perforation, which has been managed by diversion. Now the patient has come to you for a reconstruction. So the posterior mediastinum is a problem. Sometimes, not so commonly, but there is radiation given to the squamous cell carcinomas of the esophagus. So that poses some problems with the vasculature as well as the adhesions and fibrosis in the posterior mediastinum. But we personally do prefer the posterior mediastinum as a route. In the other situations, the retrosternal route is the alternative route that we can take, although it is a longer and a more angulated route.
Thank you. Another point, and it's totally from an anatomist, so I might be not spot on at it. But when we do an anastomosis which is cervical and one that is thoracic, how does the two differ? Like which one do we generally go for? I think.
Sir, in our practice, we are seeing a lot of gastroesophageal junction tumors, and for them, we do an intrathoracic anastomosis.
The cervical one is not a common practice.
The theoretical advantage earlier, it was that any leaks in the neck are better than any leaks in the chest. But I think the anastomotic techniques and our perfusion assessment is so good that even if a complication develops, we manage them so well with our critical care teams. I don't think that precludes a decision to make an intrathoracic or an intracervical anastomosis. The disease and the anatomy determines where the anastomosis is going to take.
As he said rightly, that the location of the primary is very important where you will make an anastomosis. So lower thoracic esophagus, OG junction, you can make anastomosis in the chest. So mid thoracic lesion, then you have to make an anastomosis in the neck.
I think we'll move on. Thank you. Thank you, Hamza. Thank you, Dr. Nag, for joining us online.
Thank you, sir.
Thank you, Pankaj. So the last session pre-lunch is surgical anatomy of D1 and D4 gastrectomy. And the speaker presenter is Dr. Subramanyeshwar Rao. Again, he could not be here because of these flight disruptions, but he's online. He's from the Indo-American Hospital in Hyderabad, has great experience with upper GI malignancies, and Hamza will continue to be there as a discusser, and Dr. Subhash Mishra also will join him. Dr. Subramanyeshwar. Subramanyeshwar, can you please unmute yourself and share?
Am I audible, sir?
Yes, yes, please. But we are not seeing your presentation still.
Yes, sir. Now, sir?
It says you have started screen sharing. Yes, we can see. Please.
Is it full screen, sir, now?
Yes, yes, please.
Yes, sir. Thank you very much, Kapoor, sir, and rest of the team there for being responsible for my presence online. I'm sorry I could not make it. Kapoor, sir, is someone I always thought I should have known him much earlier in life. That's how much I admire him. And that's the reason why I'm here. It's not moving.
We have lost you.
You lost me, sir. It's not moving.
No, we can hear you. We can see you, but the slides.
The slides are fixed, sir.
Is that all right,
Yes,
sir?
yes, we
Yes,
can
sir?
see now. Yes, please.
Yes, sir. And anatomy is something that we start with, and with lots of anxiety. I was like this student, and my teachers hoping that they would get some answers from me from this specimen sometime. Now I'm a teacher like Kapoor sir and others like this, having students like this. So closely interrelated over 30 odd years as far as anatomy is concerned. Surgery, removal, retaining, reconstituting, or reconstructing, everything is all about anatomy. So, and the best thing is anatomy is universal, doesn't change with this ethnicity, race, or most of the times, most of the organs, gender also. So, no change since time immemorial. So, not much to learn new, but it's important to keep abreast with it and respect the anatomy. The art of uncovering, unfurling anatomy is essentially surgery. Surgical anatomy is not necessarily the pure surgical anatomy. It's also important that the surgeon, we have been discussing this morning, that it should be radiologically very good. And then now, with minimal access that is coming up, you have tangential anatomy because the scope can turn and twist, or you call it the coaxial anatomy, to which you should be used to. If you're doing a procedure in open surgery, you have vision only in one straight line, perpendicular anatomy. And then it's positional. If it is lateral position in esophagectomy, it's different. It's in prone position, it is different. And magnification also initially can be uncomfortable. From open to endoscopic, then you have the 3D, 2D and 3D, not just for robotics, but for others also. So the what we need to understand is the one place where lymphadenectomy is important, like in any other organ system, is stomach. We have D1 to D4. Most of the stress is on D1 to D2. I would not go into the details of what is done when, but because this is mainly anatomy, groups are very well divided by the Japanese, and most of us actually follow all that. So when you're extending lymphadenectomy to D3, it's number 10, 14B, and 13. When you remove 16, then you call it D4. Laparoscopy and minimal access in general is the best way to teach and or show anatomy, because it is magnificational and it's of a high resolution. It's so much easier to record all that. So that is the anatomy. Hamza actually gave a wonderful account of what all are important. I'll not get into all that. I'll only show a few videos of how lymph nodes are important, and there's anatomy. All these lymph nodes are along the vascular system. So vessels and vascular system are important in these procedures. The number 6 is the first thing that we start with, generally with a subepiloic window, so that the momentum doesn't disturb you in the rest of it. What you encounter is the vein first, which needs to be clipped separately, and always good to skeletonize the vein and the artery separately and clip it and then cut it. The next vessel most people do is the splenic artery. The proximal splenic artery clearance is a standard procedure for the gastrectomy. the distal splenic artery is dissected only when you have nodes there or in the splenic hilum, and the landmark is the first dorsal artery, the posterior gastric artery. It's also a short gastric. So there you stop and then you complete it. So the anatomical detail is very important. You must look for the first dorsal short gastric artery and then stop there. Station 5 and the right gastric artery are isolated. That is the right gastric artery coming down. That is the gastroduodenal. So you are walking along the hepatic artery to do all this. Hepatic artery probably is the most important of all these three vessels, because the left gastric or the splenic are relatively dispensable when compared to hepatic artery. So hepatic artery component has to be dissected much more carefully. And that is the right gastric, which can be clipped very close because we are doing a gastrectomy. This is something that is preserved in a esophagectomy. Duodenum is better transected at this stage after you complete 5 and 6. I think it's good to transect because it will give you a much wider exposure. Otherwise, especially in minimal access, you'll be walking across the stomach while burning the hepatic artery and a part of the stomach also. So good to do that at this stage, at least, if not earlier than this. And then I think it's always a good idea to dissect the left gastric vein till it joins the junction of the portal vein and the supramesenteric vein, because unless you do that, the 8P clearance becomes difficult. And 8A clearance, I think it's important to clip the leash of lymphatics that come up from here, because that is the commonest cause for a lymph leak post-gastrectomy. Lymph leak can be significant, and it's much more difficult, unlike esophagectomy, to go back in and clip the thoracic duct can be clipped even with a conduit in C2. But you have a Billroth 2 or a Billroth 1 anastomosis, it's very difficult to reach this area and do any clipping in an edematous bowel and the rest of the structure. So it's always good to clip those lymphatics which run from the junction of the portal vein and the splenic vein. And then the 7, 9, and 10 are dissected. While you go for the phrenoesophageal ligament, the left gastric artery is preferably cut after you complete all this, because it can act as a tent so that your left hand can push it up. Otherwise, if you cut it initially, it can be dangling into your field and can disturb you. So artery should be cut in the end, vein in the beginning if possible. And 1 and 3 also need to be dissected, and it is done before only after everything else is completed. And it's important to stress on this step because there can be nodes even in an antral lesion. That is where the one is, if in case you are doing a total esophagectomy, you need to go much higher than this and then remove a part of the cuff of the esophagus. That is the right gastric artery. On the other side, needs to be carefully preserved in esophagectomy, but here you would isolate and sacrifice. Splenic artery can be a real spiral, and that is the reason why you keep having what is called the wandering spleen and things like that. So it's prone for injury when you think it will be a straight line, and the ascending splenic bifurcation is the vessel which is commonly injured, producing splenic infarcts, which are much more commoner in the upper pole than the lower poles. I think it's important to start from its root and then dissect laterally rather than the other way. Small infarcts are common both in esophageal surgery and in gastric surgery. That is because this ascending splenic is a very consistent vessel, and sometimes it gets inserted onto the head of the pole. So while you go laterally and then cut the short gastrics, you are uncomfortable cutting it very close to the stomach because you don't want to burn the stomach, but you'll produce this. So it's good to avoid. Most of the time, it's of no consequence, but sometimes there can be splenic abscesses that can form. So it's important to identify it, stay very close, and then even if you play a little onto the stomach, generally, if you're doing a total gastrectomy or doing a pull-up, this part of the stomach is anyway sacrificed. So it's important to understand that this can be a spiral and can go and get into the spleen on top of the spleen. Good to preserve that. And while doing a good lymphadenectomy, you have a large lymph node there, a significant lymph node on the ascending component of the splenic artery. You can see the lymph node there. So it's important to reach the vessel. It's not important not to hold the node at any point in time. Important to reach the vessel and then play very close to the vessel. There are multiple small twigs and they're all branches which are called the short gastrics. So important to dissect on the other side also. So that, and then once you have got that, it's better to stay a little closer to the stomach, especially when you are sacrificing. But even otherwise, it's fundus, which is more often than not sacrificed, except if you are doing and that's how it is. As I've told you, it actually climbs up onto the spleen and gets inserted there. So very common site where it can be injured, and you keep seeing videos both on YouTube or in workshops where infarcts are very, very common. Be deliberate in this to prevent these injuries. You can actually see that it's looping up like that and then going inside. Need to preserve this. It can loop up like that. It can lie down above the spleen in this groove. So it can be highly variable in anatomy. If you have all this technology and if you are learning from the in the learning process, I think you can highlight all this anatomy initially itself, inject this, and before you start dissecting itself, you know where these vessels are. All three vessels highlighted by, and the same patient has been dissected, the splenic, the left gastric vein actually joining the splenic vein and not the portal vein, splenic vein axis junction, that is the hepatic artery. All this can be highlighted. All this makes the surgery much more easier. Same thing to the epiploics. Epiploics also can be highlighted by ICG. Anomalies are not uncommon. You keep having accessories, anomalous origins, and then replaced vessels. Left hepatic arising from the left gastric is very, very common. It's reported in about 16 to 20%, but once we have started doing minimal access, we find that it's much more common. That is the splenic artery, all three skeletonized like this. Replaced hepatic, once again, much less common than the axillary left hepatic, but it's important to see that the vessel is there, looping around the portal vein, and it's going retroportally, highlighted by the ICG there. The artery filling while the vein is not at filled. Retroportal hepatic artery, also not really uncommon. Can be dangerous because you are searching for the hepatic artery here, you are dissected it here, and then suddenly find a vein there. And artery does tolerate insult and injury. Vein does not do that. So you have to be very, very careful. And then the left gastric vein joining the portal vein at a much higher level, highlighted by ICG. That is the portal vein there. Generally, the left gastric vein has to come down here. There is this vein that is getting into the portal vein much higher. While you're doing the 12A, you can have, you can read your scans well. Situs inversus can really challenge anybody. I had a real tough time understanding this, and it's much more difficult in minimal access because a complete orientation is different. A lymphadenectomy becomes a serious challenge in these patients. So we have seen 3 of these conditions. One of them we had to convert because I could not really decipher what to do. So these things keep happening. And then D3 and D4 are some things which we don't do regularly. This is a video of a gastro colectomy, right colectomy, where you can actually see. And the 16 group, 16B1 dissection is shown in this patient for whom the patient had a gallbladder cancer. Actually, I don't have a video of a stomach cancer for whom we did paralytic lymphadenectomy. Paralytic lymphadenectomy, essentially its anatomy, that is the renal vein. These are the gonadals, the double gonadal veins here, and this is the area where you dissect. There is the renal vein, aorta, and these are the gonadals here, and these are the ureters. So anatomy is important. What indication you want to do, as long as you learn anatomy, you know you can draw lines and resect. That's how it looks. The gonadals arising from a common root, and then the left vein, the gonadal veins, and the aorta. The renal veins, left and right renal arteries rather. So that is anatomy for number 16 dissection. Fluorescence guidance can improve your anatomical skills, both in in vivo dissection. You inject subserosally, you have many more lymph nodes that are becoming green. The number of lymph nodes increase, the yield increases significantly. What help it is for the patient, we don't know as yet. But the bench dissection actually yields many more nodes, because the green ones can be separated well and sent to the pathology by a bench dissection, instead of allowing the pathologist to report a lesser number of nodes. The mucosal injections also work well. You can actually see the lymph nodes taking up the green dye. Makes it much easier for you to dissect and not miss any nodes here. Friends, anatomy plus common sense is surgery. So eventually, if you have certain element of common sense, what you need to learn and maintain is anatomy. Surgery is a penance. So speed comes from training, temperament, and teaching. And it's important to preserve anatomy. So we are becoming more and more conservative in terms of preserving anatomy. And anatomy is the richest attribute of nature. And preserving anatomy and resecting when it is needed is very important. And that is the only tribute we can give to the Almighty for such a wonderful creation called anatomy. And that is the team. It's a 58-member surgical team with a 25-member anesthesia team. They do all this work, and I'm only a representative. Thank you very much, Kapoor sir, and everyone at JSF. Thank you very much.
Yeah. Hamza, Subhash.
Thank you, sir. It's a very nice presentation. You elaborated very specifically, and all the boundaries which lymph node has described, you shown very beautifully. My one question is that at which lymph node station on preoperative CT you decide that you are not going to operate this patient, since you said you don't operate on D3 and D4?
Correct. See, D4 we have started looking at, although we have not done a procedure as yet. Patients who respond to chemotherapy, you have a few nodes in the paralytic. We are open to actually resecting these patients. CT study wherein after FLOT, we do FLOT for most patients these days. After FLOT, there is no significant regression, or if there is complete encircling of the celiac artery, that's when I back out, because I personally feel these patients don't actually benefit.
Okay. And do you routinely do back table dissection or tag
We do it as a policy. One of our not so young, but somebody who's in the middle range visited Japan about 10 years back, and from then on, he and his team, they do the dissection. Okay. We have organ specified now. I do everything, but the rest of them do. One of them does only stomach. So they do a bench dissection for every patient, and it's done by the pinpoint camera, the open camera, while looking at the screen. It works well. you get a much higher yield. In a colectomy, we got a 150 nodes. So total colectomy it was, and in gastrectomy we got 56, 70 nodes. So keeps happening. It's good to do
Bravo,
that.
sir.
Yeah.
Wonderful demonstration. So you're giving the pathologist no excuses. My question is regarding the station 10 node, sir.
Yeah. Correct.
The dilemma has always been that should we in G junction tumors should we always go for the station 10 nodes as part of a sampling or not? So what we have started doing is, because the incidence of G junction has started increasing in our practice, what we do is we do a perilesional infiltration of the ICG, and we look for the uptake. And if there's an early uptake in the station 10 nodes, we do sample them. What do you think about sampling of nodes and the concept of sentinel nodes in
whether it's sentinel or otherwise? I think it's very important to look at the artery and the vein, and then if there are nodes, I think it's mandated. See, you have to complete a lymphadenectomy. Whether you have to stage it or not, I think it's a good idea to inject and resect. See, the problem there is there can be small vascular injuries, especially the vein can get injured, and then if it leads to a splenectomy, then the results, at least historically, the results of a patient who has undergone a splenectomy have been poor. So that's a cause for worry. But otherwise, if you have a good pair of hands, Dr. Hamza, I think you should do. We won't give it as a blanket statement, because the best pair of hands rarely would ever injure these vessels. So I think if you are good at it, please do it.
Because that was the question, because many a time we had to sacrifice the spleen when going for these station 10s. We aggressively go for station 10 because we believe that it is a draining echelon for the G junction tumors.
Do you vaccinate these patients pre-op? Because anyway, most of these patients are on FLOT chemotherapy, so you have 3 months time for you to build the patient. So do you vaccinate?
So far we have done around 10 cases. We had to do splenectomy in 2. We vaccinated them 10 days post-op.
That's perfect. Yeah, we vaccinate in while we do CRS, cytoreductive surgery, whether it is for colon or we don't do too many stomachs CRS, but colon and ovary we do CRS every day actually. So we do it as a protocol. We vaccinate all patients.
Abhilasha, you wanted to say something? Yeah. Dr. Abhilasha is my colleague in Department of Anatomy.
Good afternoon, Abhilasha.
Good afternoon, sir. It was a very nice presentation. I have one question from the anatomy point of view. As we have discussed the dissecting hepatic artery, so there is this important relation of inferior vena cava near to the free margin of lesser omentum. So are there any chances of rupture of this, because it's just posterior in the epiploic foramen? So if it gets ruptured, there will be massive blood loss or intraoperative hemorrhage. So
unless there is a lot of disease there, I think what Dr. Hamza asked becomes relevant here. If you have a lot of nodal disease in station 12, these are patients who would not, and an antral lesion, these are patients who would not benefit too well, because it's not a regional node. It's not truly a regional node. So if you have a lot of disease in the porta, I think it's not a great idea to do it to operate at all. And unless you have disease there, it's very unlikely that you will go anywhere close to the cava, because especially in minimal access, it's not easy with ports that are designed for gastrectomy or a D2 lymphadenectomy. It's practically impossible to reach the cava. So unless if you don't reach, you don't injure. And if you have disease there, I think it's good not to actually propose any type of resection. We never had anything like that. We had 3 portal vein injuries. Yes, and only once it was because of disease. The other 2 times it was using the energy tool with not the best efficiency. And we have a huge training program that happens continuously. The youngsters keep operating. So there is an element of such problems that happen. But twice I could suture minimal access. Once I had to open. It was a bigger injury, so patient was unstable, so I had to open. So you can still control it. Yes. You need all the minimal access vascular clamps. It's important if you are handling these full set of vascular instruments. The long vascular instruments are important in this.
Thank you, Dr. Subramanyeshwar.
Thank you,
very
sir.
much for joining online, and thank you, Hamza and Subhash. I think it's time to break for lunch. We are running about 15 minutes late, but we will be back here at about 2:05 or 2:10. The lunch is on the 6th floor. So if you follow me, you will reach there.